Okay, you see this here? Don't worry about it now. Look at the scenario. Anybody want to do it? Raise your hands, guys. I'm going to do either way. If you guys want to try it, go for it. She appears anxious, unable to speak in full sentences. X-rays of the chest are shown to the right. I'm not looking at it yet. Please, I'm not looking at it. Examination is, what will you see? We have chest auscultation, chest percussion, chest expansion, tactile premise. What's tactile premise again? Put in chat box. What's tactile premise? Plus, wait, little side note. Egolphony. Egolphony means you tell the patient, "Hey, Mr. Smith, I'll put my stethoscope on your chest in the back. I want you to say E." When they say E, you hear A. Consolidation. Mr. Smith, yeah. I want you to whisper. 1, 2, 3. Please whisper every time I put my stethoscope on your back. So they're supposed to whisper 1, 2, 3. You hear loud 1, 2, 3, which means consolidation. So whether it's tactile parameters, egophony, whisper pictorially, they all are indicating consolidation of the lungs. Something's there which amplifies the sound. Okay, good. So yeah, that was a long answer to the short answer of pneumonia. As you tell, I love to tell stories. I connect everything. That's just what I do. You can't change it. That's who I am. All right, we'll go to the top. 23-year-old woman, ED, because of 2-hour history of shortness of breath. She's a atopic history of atopic dermatitis. She doesn't smoke, doesn't do drugs. Okay, fine. Temperature's fine, resp is 28. She appears anxious, unable to speak in full sentences. Let's check this out. I don't know. You guys are good at radiology? I hope so. Okay, there it is. What do you think it is? Do you see anything wrong with this? See what they're pointing to? Okay, all right, let's follow with this. Quick question. Can we knock anything out right away? But what do we have in this case? Any idea? Can we knock anything out immediately? Immediately. Any clue? Any clue whatsoever? Because now, history of atopic dermatitis. She doesn't smoke, doesn't drink. She really feels anxious and unable to speak. Do you think it's chronic bronchitis or pneumonia or anything like that? Any idea? Tactile increase should be gone. Yeah, right? Because why, guys? Why should tactile firmness be gone? Because that indicates pneumonia, doesn't it? An infection, doesn't it? She has no temp here. And also, it's not an infection. It's more like what? Like an asthma attack, maybe kind of like, because she has atopic dermatitis. She can't talk in sentences. Some issue going on. So isn't it fair to say we could take out tactile fremitus? It's decreased? Yes. So to attack these tables, the best thing you could do is go with what you know first. Don't let it affect you. It's scary, I know. But look at the variables. Tactile fremitus. Decreased, decreased, decreased. Good. Because we don't have consolidation. This is not pneumonia. We take out C and D. Boom, boom, out. Now, chest expansion, chest percussion, chest auscultation. Hard, isn't it? If a person has asthma, like a severe attack, is the expansion going to be asymmetric or symmetric? Maybe you don't know the answer. Then we move to the next one. Percussion versus, you choose, guys. I want you to choose. Are you going to choose chest auscultation, chest percussion, or chest expansion, which is easy for all you all? Has to be something, right? Has to be something. Take out dull chest percussion. Right, he says. Tactile increase should be gone. We have our ideas and suggestions, right? Chest percussion, she goes, dull should be out. Okay, take out dull. Dull is out, so we keep hyperresonant, hyperresonant. So we have these guys still in play. And the rest is out. Yes? Yes. So we're down to 2, everybody. We're down to decreased breath sounds, hyperresonant, and decreased breath sounds, hyperresonant, and decreased. They're all the same. The difference is what? It's either going to be asymmetric or symmetric. What would somebody be what would something be asymmetric? Where would you see asymmetry? Pneumothorax, spontaneous, right? Pneumothorax, tension pneumothorax. Spontaneous is it collapses on one side. Tension is expands and pushes to the other side. You've seen movie Three Kings. I think it was George Clooney. They're in the desert. These guys are American soldiers, and the guy he breathes and he's gonna collapse because he has, I think it's tension. So they have to make an opening, put a straw in there to relieve the air, right? Or else he will eventually not stop breathing because he keeps expanding. So when you see asymmetry, doesn't happen. That doesn't happen in asthma. It's symmetrical. Asymmetry happens more of in tension versus spontaneous pneumo, right? One side collapses or one side it deviates because of tension. It pushes to the other side. So automatically, these are all the same findings, but it's not asymmetry, it's symmetrical. So to hit this question, you kind of need to see the photo or understand that it's not pneumonia. The fever's not there. The person has asthma, especially history of atopic dermatitis. And if I'm not here to help you, here. The chest x-ray shows radiolucency, flattened diaphragm, okay, fine. But a person who does not smoke, has a history of atopia, you might be considering severe asthma attack. So either you can check the chest x-ray and understand it, or you can actually understand through the scenario itself. And that being said, always go through something you know. Tactile phremesis is more of consolidation. So obviously it's decreased. You don't have an increase in consolidation. I then went to either percussion or expansion. I would think asthma is more symmetrical. Done. There's the answer. You get it by two points on the table. If you go to chest percussion, hyperresonant, yeah, because they have asthma, a lot of air, right? Then you go to chest auscultation. Clearly, it was not a deciding factor. It's the expansion that was able to help us differentiate. And that being said, the answer would be E. And again, 31% chose it. Very tricky, and I know why. I really think that the picture throws people off. I also think that people are not comfortable with the presentation. Maybe they're not comfortable with any of these findings here, the table with the variables. So I'm showing you ways to leverage the test. Now you know more about pneumonia versus asthma. You know what findings you'll see in pneumonia. You could appreciate more of what they're going to give you on x-ray. And you take your time. This is concerning. 17, 16, 25, 10. That's not good because, I mean, I can understand it. But look at this one. A is what? Atelectasis. Yeah, well, yeah. I mean, decrease, asymmetrical, dull, and decreased breath sounds. Yeah, it's collapse. And then this one, B, we talk about pneumothorax, right? Asymmetry, pneumothorax. Again, tension versus spontaneous. It's either one or the other. So if you know spontaneous, you'll know tension. If you know tension, you know spontaneous. 2 for 1. C, pulmonary fibrosis, pulmonary edema. Okay, so fine crackles, dull, symmetrical, increase. Yeah, there's some sort of consolidation, a fibrosis, something dealing with tactile phrenitis, right? There's something in the lungs, whether it's phlegm, infection, or fibrosis, something is there. And this guy here, D, check it out, learn it. Lobar pneumonia. Okay. But we talked about pneumonia before, right? We know about most commons. This person doesn't have pneumonia. Not only that you don't see any consolidation here, at the same time, this doesn't present like pneumonia. So either you use the x-ray or you look at the presentation. One or the other, right? You need to know one or the other, if not both. That's why respiratory is fun, because you can get a lot of points here. It can also hurt you. That's why you can't let it hurt you. I chose about 9 questions for this one. I want you to go to the other ones on your own.